giving more awareness about the current situation and the future. Thank you very much, Dr. Yasser.
الله يخليك يا فندم، اتشرفت بحضرتك جدا، وإن شاء الله نتقابل فيس تو فيس بإذن الله قريب.
Thank you very much, Professor Ashraf. It's a very honor to have you on actually this seminar, and to actually open this is now his webinar, as you actually advise us following the regulation of the government. And it's also honor to have Professor Shenawi, the Vice President, with us. And I think Professor Tar Abul Maati will join us, if he's already joined or not. And Dr. Yasser El-Sherbiny is I will say, one of the COVID figures these days, and I hope he's going to actually give us talk about COVID challenges now and future. And I think Dr. Yasser, Dr. Shenawi, would you like to say a few words at the beginning?
Of course. Good morning, everybody, and it's an honor to have Professor Ashraf Haider, the president of Galala University, and I hope that Dr. Tara Abul Maati, the vice president, also for academics, will be available. And I would like to start by thanking all of you and Dr. Dessouky and Dr. Yasser for being here today and all the attendance of this important webinar. And as we all know, that the central topic of today's discussion, as Dr. Ashraf was mentioning, is the COVID-19 current challenges and the future. And we know how that the COVID-19 has drastically impacted millions of lives through various aspects and elements. And I think as scientists and physicians, looking at this pandemic, its response and its ramification through a biomedical scope is not only our interest, but our study. And I hope that we'll hear from Professor Sherbini, but before we start, let me mention to you some figures. In Egypt, Professor Sherbini, that in Egypt we have more than 300 running projects in different universities, more than 720 PubMed index research articles, around 160 registered clinical trials, 15 projects funded by STDF and 80 funded by ASRT, and more than 270 complete viral genome sequence were reported by Egyptian scientists. Just to show these some of the figures that Egypt is doing. As regard the vaccine, we see the vaccines, and we have 4 vaccines from Egypt in preclinical trials according to the WHO, and we hope that we'll see an Egyptian vaccine in the near future. I will not talk a lot, but really looking forward to hearing from you, Professor Sherbini. Back to you.
Thank you very much, Dr.
Thank you very much, Dr. Thank you very much, Dr. Shenawi. And I see that this webinar is recorded. So it would be a great opportunity to have this webinar posted after its completion, and the very fruitful discussions and points that will be mentioned in this presentation. I really highly appreciate Dr. Yasser and Dr. Dessouky, of course, and Dr. Muhammad, and everybody who shared in having this done. Thank you.
Thank you very much, Dr. Ashraf. Thank you very much, Dr. Shenawi. Dr. Yasser, the screen is yours now, Dr. Yasser.
Thank you very much. I would like to repeat my thanks to all of the administration of Galala University and the host, Dr. Hassan Dessouky. Professor Dessouky was actually asking me to do that, and without the sponsorship of Dr. Shenawi, Dr. Haider, and Dr. Abul Maati, it wasn't happening. And thank you for putting me on your first webinars of Galala Universities on this. This is actually very good communication, and you can do that with all of the scientists and professors around the world. So it's a good channel for updating you on every update on the science field. So I would like not to spend a lot of time, but I would like to thank sincerely Egyptian Academic Together and Dr. Walid Amara, who has actually sponsored this webinar also by hosting on the Zoom channel of this and providing the admin support. So I'm Yasser El-Sherbiny, and I'm working as an immunologist and a professor of clinical pathology, and at the same time senior lecturer of biomedical sciences at Nottingham Trent University. So let's talk about COVID a little bit. So what is the COVID and what is the SARS-CoV-2? You hear about these two terms all of the time. So the SARS-CoV-2, it's a new coronavirus similar to the SARS-CoV, which appears actually about 2 years ago. And it's named SARS-CoV-2 because it is severe acute respiratory syndrome coronavirus 2. This is actually the acronym of SARS-CoV-2. A lot of people say that where does this come from? And the COVID-19 is the disease caused by this virus. So the disease is COVID-19, the virus is SARS-CoV-2. So the COVID-19 is coming from the coronavirus disease, as you see it here, and this is the acronym 2019. It starts an outbreak in Wuhan in China and becomes an epidemic after that. And the epidemic means it was actually suddenly increased in numbers. And after it spread in about 220 countries around the world and about 1.8 million deaths, it's considered a pandemic. Not usually the people name any epidemic as a pandemic, but it is the worst medical condition or medical disease happen for our human beings actually in the last 100 years. Why that? Because it's affects about 84 million people and it's spread all over the world. Maybe it started in Wuhan in China, but believe it or not, actually it spread more now towards every corner in the world. And we know that it's actually in Egypt, we got some cases. Actually, we have about 140,000 cases recorded in Egypt, and our curve is going into the second wave. Unfortunately, we have a lot of death caused by COVID-19, and this death is actually not specifically in certain part of the world. So it's a global problem that you cannot restrict it to certain geographical or demographical or economic condition. In Egypt, in particularly, we have a high percentage in the last 4 weeks of death, but believe it or not, also in United Kingdom, we have also this rate of death, and you can see it in color here. We reported about 7,576 deaths as recorded by the World WHO. And this is the last report I've seen. Actually, maybe there's something updated after that. On the 1st of January, we have 1,400 cases in Egypt. So we've been hit by this virus also in Egypt a lot. But believe it or not, in Egypt is much better than the UK. This is actually from last night. In the 2nd of January, we got about 34% increase of the cases than before. And this is actually take the cases to about 57,000 daily. This is maybe because we are doing a mass testing, but also this is associated with increase of the patient admitted to hospital in 20% in the last week, increase of the patient admitted to hospital. Actually, they are gasping for medical support now, and the deaths also start to jumping up on this disease. I'm not an epidemiologist. I wanted just to show to you how this global problem affecting every part of the world. In the US is the most worst country, 20 million people affected, and it's more toward the East Coast than the West Coast. And this is demographically maybe because the disease spread from the East. Also, our neighbors in Saudi Arabia have the same problems, and we have thousands of cases over there, and actually more recorded cases in Saudi Arabia than in Egypt. It's maybe irony that you see actually that Wuhan and China reported in the last 2 days about 370 cases only, which is something maybe to be considered. I don't know if they are actually showing the right data. It's a disease which transmits very easily, like airborne infection. And that's why you see it in the form of I would say, people in close contact with each other expel droplets, and they are, and usually the cough or the sneeze in the nearby, or touching the surfaces which have this contaminated droplets actually transmit the disease. Why I have to say that? Because I'm a doctor, and actually I have to aware the people about this, how the contamination happened. And everybody asks me, is it happened by touching surfaces, or it's happening due to the droplet infection? They are the same, actually. They are touching the surface, and touching your face is the same. So wearing mask is essential, and keeping social distance of 1 to 2 meters between the people is very important to prevent the disease, and to avoid actually coughing and sneezing and spreading the droplets around. You see that everywhere in the social media and also on the TV, what you do, what you don't have to do. I mean, I'm just encouraging the people to do all of the instruction. All of these instructions are actually for your protection, including isolating yourself, trying to stay at home if you cannot actually work from home, unless it is necessary. Keep ventilating all of the area, and keep sanitizing your hands, wash your hands frequently, and keep the social distance. If you have to cough or sneeze to protect the others, just do it in your elbow. In the same time, don't touch your face or hands unless you wash your hand, and also try to avoid touching surfaces or actually on the stairs or something like that, and don't shake hands, as we have the problem in Egypt. The people actually are a bit emotional, and they like actually to hug each other. This is not the time for this type of greeting. Avoid the crowded places as much as possible. Use a private transportation, as most of us doing at the moment, and avoid traveling if you have any symptoms or signs. It's a disease with very common types of symptoms and signs. It appears in the form of fever or cough. However, me myself, when I got COVID-19, and I got it actually a couple of months ago, I got it in the form of headache only. So, and some people, they got actually loss of smell, some not. It's different between each part of the world, that we have actually this type of disease in a different formats. But I have to emphasize that some people may have no symptoms at all, and they can spread the infection, and that's what we call the carriers. And most of the cases are mild, and they are not severe. You won't see actually the COVID-19 severe unless it is actually in a very small percentage of the people. Believe it or not, this is the truth. And that's why we need, if we feel any symptoms or something, to self-isolate and give yourself a little bit of rest and isolate yourself from the others. This disease, caused by a certain type of virus, belongs to the nidovirales order, and from a certain family, and it's a coronaviridae family, and the subfamily is coronavirini, and it has cousins and brothers and sisters from the same family, which cause actually the actual cold that we have. So this cold that you get actually in the winter, it's usually caused by a coronavirus. There's about 4 or 5 actually known viruses causing this type of disease. But the COVID-19 is a very special virus of this family. They link actually the coronaviruses with animals usually, and in particularly bats, and I will mention that in a second. But they believe that it has intermediate hosts, like if it is MERS of this coronaviruses, it's happened in camels. SARS before was it in certain types of cats, but this type of coronaviruses goes through the what's called pangolin, and they thought actually at the beginning of this epidemic in Wuhan happened due to the consumption of these pangolins illegally actually sold in certain parts of China. This is a very rare and dangerous species. That's why it is illegally to be sold. And believe it or not, they think that this is actually was the host which the mutation or the new strain of Wuhan started in it. I will jump into the diagnosis because everybody thinks nowadays about how we diagnose the disease. And I have to say that the only gold standard for diagnosis of COVID-19 is the the PCR or RT-PCR, and it's happened by taking a swab from the usually the oropharyngeal cavity, and actually taking this swab to a PCR and amplifying the genome of the virus. There are other methods of diagnosis like the RT lamp or the lateral flow for antibodies, but these are not diagnostic, and I don't recommend using it. And we know that for the easiness of mass testing, they try to do other antigenic tests on site, but still the gold standard is a PCR. So if you want to confirm for WHO or any part of the health organization in the world that we have a case of COVID-19, they take only what's the PCR confirmed. So what is this SARS-CoV virus? It's very simple virus, believe it or not. Our enemy is about 30 kilobase single-stranded RNA virus. And this virus is very simple in its structure that it is not so difficult to understand its mechanism of action. But this simplicity actually make it also more complicated into that this virus is actually mutating itself very fast. Not very fast as the most, like the influenza virus, but it's considered as a moderately mutating virus. And I will talk about that in a second. The most important part of its structure, beside the matrix and nucleoprotein, which protect this RNA virus, and is the envelope protein, which is very similar to other viruses, is this spikes, or what we call the spike protein, which make the crown for this coronavirus, and this is hence the name we have. And these spike proteins are actually very important for the function of the virus, because it uses this arm or this, what you call leg, whatever you say it, to rest on this a certain receptor on our cell surface, which called the ACE2 receptor. This ACE2 receptor is the gate or the hand that allow this virus to go inside the body and inside the cells. And unfortunately, this ACE2 receptor is spread all over our bodies in a lot of tissues. Yes, the mechanism of entrance requires certain enzymes like TMPRSS2 or other like furin, but in the same time, the distribution of the ACE2 in every tissue in the body allow the virus to penetrate every tissue nearly. Yes, it hits actually the lungs and nasal cavity mainly, and the gastrointestinal tract because of the abundance of the ACE2 inhibitor receptor over there, but it is still actually very dominant. And it is especially out of the coronavirus family, SARS-CoV-2 has very high affinity to this this receptor ACE2. For example, the SARS-CoV-2 is actually the second on this one, and there is a big difference you can see in this curve between the binding of the COVID-19 virus, or what we call the SARS-CoV-2, and the other SARS virus. And as much as the virus has much better binding to this receptor, the infectivity increase. So simply, if this virus enters inside the body and bind to the ACE2, they start to go inside the cells and release the RNA that we have and assemble new viruses inside the cells. This is simply, and we try to, most of the viruses work that way. And to oversimplify the immune system and the immune response, the virus will be ingested or digested by certain antigen-presenting cells, which presented to the adaptive immunity, which start to make antibodies, or the T cells start to attack it and kill the virus. It's not simple as you think like this. To be honest, I wanted to take you to another direction a little bit, which a lot of people, they don't know about it, or maybe they are not aware about it, or they are not focusing about it. COVID-19 or SARS-CoV-2 is actually governed by the first few days of infection, which happened due to the presence of what we call the innate immunity. So the first 4 days or 5 days, we have this what we call the innate immune response using natural killer cells or interferons. Type 1 interferon is my specialty, of course, and the BDCs, which are sharing to recognize this dangerous virus and none seen before. And believe it or not, we have certain type of people. A lot of people have been asking why the Egyptians are resistant a little bit to the virus, why the numbers are low in Egypt and higher in the United States and UK. Maybe because of this pre-existing antibody. What is the pre-existing antibodies? These are germline encoded antibodies, which are providing the early and sufficient protection against the cytopathic effect of this virus. And everybody trying to ignore it and thinking that all of the memory that we have and all of the immune system working through the B cells, antibodies, and the T cells, which gain after exposure. Actually, it is not. These pre-existing antibodies may be enough to neutralize the virus and stop it. And it is not my say that this innate immunity is governing if the disease is going to be mild or moderate or severe. It is actually Rolf Martin Zinkernagel who actually pointed to that about a few years ago and published in 2018. Can you mute the mic, please? Yes. So Zinkernagel actually explained that some people, they do have this type of pre-existing antibodies, and these pre-existing antibodies are sufficient to stop the viruses from entering inside the body and actually neutralize the virus. And these pre-existing antibodies are different between the people. They are not memory. They are actually pre-existing in your signature of immune signature. And I'm just going back to show you, it happens in the first few days. So they didn't see the virus before and it happened. And I was actually wishy-washy about that until I've seen the science paper, which came on the 11th of December by a very important people in the immunological field, which say pre-existing de novo humoral immunity to SARS-CoV-2 in humans are actually showing that we have some people are immune against the virus and some other they are not immune naturally. They have from the beginning. So this is actually their statement that the SARS-CoV-2 glycoprotein reactive detectable by flow cytometry antibodies are prevalent in the children and adolescents. So this may explain also why the children and adolescents from this factor are protected a little bit. And this SARS-CoV-2 uninfected donors serum, so this serum from the uninfected donors exhibit a specific neutralizing activity against the SARS-CoV-2 and in particularly also the SARS-CoV-2 S pseudotypes. So maybe this is why we have different it's not ethnic now, it is related to the immune system signature of pre-existing antibodies. And these antibodies are real and not a background and not shared and cross-reactivity. It's not an antibody against another virus and cross-reacting with this virus. No, it is specific antibodies which work on COVID-19, and it has a very high affinity and exist in the people. And maybe we are lucky in Egypt to have them in our clone. So I wanted to drag your attention about that. Yes, we know after these pre-existing antibodies that interferon or type 1 interferon and the other innate immune cells, we have seen actually a recent publication which just came in October and August in Science also, which confirmed the importance of type 1 interferon about that those which are going to the severe infection or the severe disease are usually having an impaired response on the interferon. This is the short message. So pre-existing antibodies, the presence of type 1 interferon beside the other immune cells, innate immune cells like NK cells and BDCs are actually starting the fight and maybe eliminating 80% of this disease directly from the scene. So why people have been asking me also why COVID-19 affecting adults but not children. This is maybe explained by a lot of theories, but I would just mention few of them which are interesting also. Some people say that it affects, increase the risk on the adults because some of the adults having high hypertension, having endothelial damage, they have smoking, which affect the endothelial surface, which allow more viruses to go in. ACE receptors are more in the adults than the children, which actually the receptors for the virus. A pre-existing immunity, which is, I will tell you now in a second how this can help to the virus to go inside the cells. Immunosenescence and inflammation, which is a pre-existing actually condition which happen over ages, and that's why we find that the 70 over people that they have more disease. And believe it or not, the vitamin D deficiency, which we see it in most of our females in Egypt because of maybe they are not seeing the sun enough, or they have a very low vitamin D in their blood. So this is actually also make them weaken, and actually this may predispose to the adults to be more prone to the disease. Factors which protect the children, there are a lot of hypotheses, and some of them evidence, some not. And this is just like recurrent. They believe that the vaccination program that we have for the children, especially early ages, protect in the form of enhancing the immune system. Recurrent and the co-current infection, which happen due to the cold, believe it or not, that the children which have a lot of cold infections and they do have runny nose all of the time, they actually more protected against COVID-19. Something which interests me, which is the melatonin. The melatonin is higher in children, and this melatonin, which is higher in children, we can link it back to the bats, which we say that it can go through the animals, and mainly the horseshoe bat, as you see, having very high levels of melatonin. So this melatonin may be linked, but there is no evidently evidence which link that with the protection against the COVID-19 or the coronavirus. And off-target effects of certain live vaccine, as we said, and the exposure, because usually the adults are more exposed to going out to work and going out to go to the cafes or clubs or something like that. So they are more exposed to the virus more than the children. I'm trying to explain why the adults more than children. However, these are changing very recently due to the presence of the new strains. In the disease, when it is happening, when the disease happened, it's usually happened due to the when the virus goes inside the cells, especially in the air tract, it creates what we call the pyrocyptosis inside the cells. I want you to remember that the word pyrocyptosis, because this is how the disease starts after getting inside the cells. And due to the pyrocyptosis, there is a release of a lot of oligomers and the presence of ATP and IL-1 production. And this is actually may cause actually the damage of this endothelial cell and start to recruit other cells into making an inflammation and release a lot of cytokines. And the other neighbors respond to the neighbor which is infected by the virus and start to support them by calling for help and shouting for help. And this is what we call the cytokine release. In the worst scenario, this shouting and this response from other cells toward the infection of the virus, it start to make this defective immune response. And this defective immune response, there will be a lot of screaming and shouting from these immune systems and from other cells around. And this is caused what we call the cytokine storm. I would say that. I don't want to explain it more than this. That every cell is shouting with a certain type of cytokine, whatever the type of the cytokine. But what is interesting is the presence of non-neutralizing antibodies, which may help the ADE infection. And this is actually something been raised very recently. We say that some people having a pre-existing antibodies and give them protection. The antibodies that formed by the human being, and if they are not actually neutralizing the virus and stop the virus by neutralizing the S protein or something important for the the protein, the virus to act, it will help the virus to go inside the cells, because antibodies which attach to the virus, they may attach again to the Fc receptor and intake inside the every cell which have Fc receptor in the body, and enhance reinfection, what we call the antibody dependent enhancement of the infection. So antibodies which are not killing the virus are actually helping the virus to get inside the cell. And this is been noticed in the people which they start, and after 7 days, they develop the disease worse. So they say that they start okay, and then after 7 days, when the antibodies form, there's no neutralizing antibody and start to go into a worse cases. In the normal cases, we have this neutralizing antibodies which eliminate the virus and neutralize the virus, and the alveolar macrophage help into eradicating these viruses which are neutralized with antibodies, and everybody's happy after that. So I'm just giving you the contrast, how the good scenario happen and how the bad scenario happen. A lot of people also ask me about the coagulopathy and what is happening. The viral infection, in particular SARS virus, enhanced with this cytokine storm and the infection, a lot of adhesion molecules, and the release what we call the tissue factor. And this tissue factor is released by the endothelial cells, which are affected by the virus, or also by the cytokines coming from nearby, or by the monocytes. So we have the tissue factors on both sides, which enhance what we call the extrinsic coagulopathy or extrinsic coagulation pathway. In the same time, neutrophils, they are coming to the party, and they start actually releasing their nets and their DNA traps to trap the viruses and trap the microbes. And this is stimulate what we call the intrinsic coagulation pathway. So we have two stimuli or two sources of coagulation, and this is cause a lot of emboli and a lot of coagulation which happen in the alveoli of the lung, and also happen everywhere in the body. And this is why a lot of clinicians now, they do like to look into the virus itself and monitor the condition of the patient by looking for the D dimers, for example, or the platelets activation, or the fibrogenemia and the consumption of the fibrinogen. And this is explained actually why these are asked for the laboratory investigations. However, this clotting which happen in the lung is the cause of all of the problems, and that's why they give antibiotics to prevent the secondary infection by bacteria and all of these things. So this is in fact what they are using the antibodies for. So I tried to summarize what's happening and why the clots happen in these patients. What is the outcome in general? Believe it or not, that 50% of the people go and asymptomatically and nobody notice. They go to the virus, they pass the virus. Everybody said that it's ranging between 4 to 80%, but I would say 50% of the people, they don't notice that they got the virus and that passed. So maybe you have to check yourself after every 2 months to see if you have the antibody or not. And this is accidentally discovered. And usually you see it when the people are traveling and they are going into Saudi Arabia or going to anywhere in the Gulf, and they do the test. Accidentally, they discover that they have the virus. However, the symptomatic cases, 80% of them, or more than 80%, are mild or moderate, and the severe cases about 40%, and the critical only 5%. But 5% in millions, this is actually fill all of the hospitals, and that's why we have this problem in the UK and all of the world. The case fatality rate, I would say that it's not high as SARS. However, it's variable between the countries, as we say, due to the health facilities, due to what we have around us, and to supporting the infected patient. I'll not go into the therapy a lot, but I wanted just to drag your attention, because we know how the virus goes inside the cells and use it. We try to use every type of therapy against this virus, including convalescent plasma, which contains antibodies, and I have a conservation about this. Hydroxychloroquine mentioned a lot of these things which can stop the virus from replicating inside the cell, or some of the antibodies, or some of the drugs which stop the cytokine storm or try to calm down the immune system, because we said that this is the pathogenesis which happened in the lung. But believe me, unfortunately, no definite therapy which can treat the people 100%. A lot of people which have been taking remdesivir or have been giving hydroxychloroquine or have been giving convalescent plasma, there is no effective treatment that I can say that this is actually work in more than 70% of the cases or something like that. No 100% at all. Lasting immunity, there is no enough also information currently to say to you that how long the infection. So you got the COVID-19 and you passed it. Are you immune? How much the time that I will be secure from other infection? There's no evidence about that, and no study have been showing the type of the immunity which lasts, except some of the few cases which have been reported. But we think that it's maybe about 3 months based on the previous experience. But and reinfection can happen, so protect yourself forever. Even you got COVID-19, you can get it again, and I will explain in a second how. In the UK, by the end of the September, or we start to see this orange type of strain which have certain type of gene mutation in the S spike. And this is by the 18th or the 12th, you can see actually it constitutes about 80% of the population. And you can see actually this is corresponding to the jump in the last few months. You can see this is December, a jump in the numbers reach actually now 57,000 yesterday. And I have to say that this is maybe due to, I'll just show to you this video over and showing to you how this is trained. This is represented the hierarchy of the mutation which happened into the Wuhan strain, and you can see this starting in February or January, and how it appears actually in some of the Europe countries. I didn't like to show the global one, and you can see that it was limited a little bit on certain types of mutation, but the mutations happen naturally or in this type of strain. But if we focus on the United Kingdom, and especially in the north of Europe, you can notice actually that United Kingdom, by the, I would say that's end of September, we started having this strain or variant, I would say, not a strain, because a lot of people complain about the word strain. And you can see here the expansion which happened of this variant, which also present in certain parts of Denmark and the north of Europe. And this is the green one, which expand to constitute very large amount of the available strain which contained from the patient in the UK. This is actually makes us
Dr. Yasser, excuse me, Dr. Yasser, if you can sum up within 3 minutes, because some staff have teaching duties after 12.
Okay.
And we would like to 15 minutes for question or Q&A, please.
Yes, of course. So I would like to say that this strain is actually the cause of the problems at the moment, and this is why we are endangered, and why this strain happened. We believe that this is because we treated some patients who using a convalescent plasma which containing some neutralizing antibodies, and every time we have been giving this convalescent plasma for this patient, for example, this is a theory, of course, and this is confirmed by Gupta from Cambridge. I would like to say that we have now a lot of types of vaccines, including inactive vaccines which inactivated the virus, including the Sinopharm one, live attenuated one, and also which are derived from the recombinant spike proteins and other viral particles and recombinant vaccines. The most important and most famous one, the AstraZeneca, which is very similar to other types like Sputnik, is replicating incompetent vectors, and the replicating competent vectors like Merck, actually they faded a little bit. The most famous one, the Pfizer and Moderna one, which using messenger RNA, they are just included the spike gene into the cover. I have to say that what's licensed now all over the world is only these 4, and I'm lucky to say that in the Ministry of Health in Egypt actually choose to have Sinopharm and AstraZeneca, which have a lot of advantages to be used in Egypt. The Sinopharm and AstraZeneca, they can provide actually the immunity that we are looking for. However, the AstraZeneca, I believe that has a little bit of much better preference on the T cells. In the UK, we bought actually 350 million doses of this type of vaccines, even before licensing. So we have actually enough. It is the logistic problem now for giving all of the people this type of viral vaccine. Who cannot take the vaccine? The pregnant women and the children. Why? Because we don't have enough data about that. Which vaccine I can get? I don't think it is your choice. Why we did all of these vaccines and preclinical studies? Because 7% of the vaccines only goes to the final stages. I created this Egypt HG COVID hub, and this HG COVID hub, I noticed that in Africa, we don't have any research, and Egypt is my country. So we created this group. I'm honored to be a leadership of this group. And we got actually some collaboration from Helsinki and from KTH from Sweden. And we started working on this. And soon we are a data contributor, and you see actually us linking between the genetics of the human and the susceptibility to the infection. And we got further funding from Easy Genomics from the European. Please vaccinate yourself and follow the instruction for prevention. Thank you very much. I'm ready for any questions. Any questions?
Okay, Dr. Yasser.
Hello.
Aywa.
Dr. Yasser, thank you very much. It's a very interesting webinar on one of the hot topics issues these days, and I think because you are the admin, or you may have the host, I will leave you to actually.
Yeah, I'm a co-host, so I'm just looking for the. Yeah, I'm just looking into the. The chat at the moment. There's nobody mentioned, so I'm just open to anybody actually who wants to.
Yasser, this is Mohammed Shenawi. Thank you so much for this extremely interesting webinar and this talk. I really enjoyed it. I totally agree with you when you were mentioning vaccinate yourself. But when you're talking about the lasting immunity, you're mentioning that we don't know yet how the lasting immunity is going to be. Are you going to be reinfected? So I think you understand my question now. Yeah, we'll be vaccinated.
Yeah, I know.
What about the lasting immunity? If I'm vaccinated, how's my immunity going? I know it's very early questions, but we'd like to hear from you in this regards.
Thank you, Dr. Shenawi. It's very, very spot-on question, because this is the most important question at the moment. All of the studies done about vaccination, no one had the time to do vaccination for a long period of time. Usually we take 15 years. As we said that we did it in about 1 year. So we didn't have the chance to see how much the immunity is happening. And we've been lucky to have the studies which show the type of vaccination, the type of immunity coming out, the T cells and the antibodies. So based on that, they suggest that this is at least will be for 6 months to a year. Okay, but this is based on the previous knowledge of immunity and immunology and how lasted is the clone of the antibodies happen. But I would say actually I'm optimistic that we may have actually to go for this vaccination for 1 time a year. And I have to remind you, sir, and you are understanding that the FDA and all of the regulatory, they've been looking for a vaccination which exceed the threshold of 50%. So if any vaccination which can immunize yourself more than 50%, this is important in this pandemic, just to stop the pandemic, just to stop it. Because once you stop it, we can improve. We can improve the antibodies, we can improve actually the vaccines. And at that time, we may look for vaccines which give you immunity for maybe 2 years, 3 years, 4 years. However, I'm not optimistic about that because the coronavirus, it looks like the flu virus is very evolving. As I showed to you, some strains, they just evolve. So we need to revise the clones that we have every year and improve our vaccines also. Thank you.
Okay, we have here Abdul Razik has a question, please.
Thank you very much, Dr. Yasser. It was a pleasure listening to you. Actually, it's very important point talking about COVID-19. And actually, it was surprising to me when you said that a person can get reinfected from the same strain. I'm not sure how the biology of this goes, or do you mean that you have a different type of the virus, or are we sticking to the same virus? So if someone gets an infection from one strain and he can get reinfected later with the same strain, if I can say strain. I know you said
I know
this word.
It will be the person will be infected with the same strain but with a different variant.
Okay.
This is what I mean. I mean, it maybe I mentioned it's not strong enough. The coronavirus that it came out from Wuhan is not existing anymore. We have thousands of mutations happen, and modified actually the strains that we have, and produce a lot of variants. And believe it or not, I didn't focus on it. GOPTA showed that in one patient which had been given convalescent plasma, every time that he was actually killing one clone of virus, there is another clone coming out. And yet, after 100 days of treating with remdesivir, COVID, all of the drugs, all of the battery that they have in Cambridge, he died at the end because he developed actually 5 variants during the pathway. And this is how the theory came out that every strain coming out is coming out because you didn't eliminate the virus very fast and they stayed in the immune compromised patient and he formed certain antibodies. The antibodies are زي ما بيقولوا الضربات اللي تقسم ظهرك تقويك. Antibodies اللي ما عملتش elimination للفيروس, it immediately allowed the virus to evolve and the new strain coming out automatically. And this is how we are thinking that the convalescent plasma is not. For example, Regeneron antibody, which actually used for the treatment of Trump, is not effective at all on a few strains, few variants which came out actually in the last the B117 that it is in the UK at the moment is completely inefficient for them. So you have to be careful when you are treating with convalescent plasma.
Would it be possible to have another question?
Yes, we have a few questions here.
دكتور وليد, if we still have معالي رئيس الجامعة الدكتور أشرف حيدر, we would like to hear from him if he's still with us.
Professor Ashraf, please. He's muted. Professor Ashraf? Okay, we'll get a question while Professor Ashraf is just busy. Okay, so we have Ahmed Rizk. Please.
Yes, thank you very much, Dr. Yasser, for your lecture. Just I have a question regarding domestic animals. Is it possible to be infected and also can transmit infection to a human being?
Yes, it is a question which came out. It's not documented that they can actually transmit the infection, but they can be carriers. They can be like your table. They can actually have the virus on their surface for enough time to reinfect somebody. That's why they said that if you are playing with your dog or your cat, you have to wash your hands before actually playing with them, because you may transmit the virus to them. They may not infected with it, but they will be carriers for them. Carriers means, yeah, the carriers not in their throats, but on their surface.
Okay.
Okay, thank you. Is still Professor Ashraf with us? Okay, Ahmed Rizk, it's your turn, please. What's your question, please?
I have two questions already. I would like to thank Professor for his excellent presentations. The first question is about the pre-existing immunity, because he said it's not result from a previous exposure to the virus or a cross-reaction from different viruses. So what is its origin? I mean, how can this happen?
Yeah,
he suggested that this is the reason why Egyptians are not having the same infection response like other populations in the world. This is my first question. My second question is this about the committees that you have developed about the Egyptian researchers for COVID-19. Is there a possibility to perform clinical trials for already presenting drugs? I mean, for example, in France, they were testing the effect of chloropromazine, which is antipsychotic medication, to target the COVID integration inside the cells by alkalinization of lysosomes. Because this is one of your slides, you said that we can complete the virus at different stages, even inside the cell, to prevent the replication of RNA, the release of RNA inside the cells. So I want to know, how can I join this committee, and if there is a possibility to do a clinical trial on already drugs. Thank you.
Thank you, Ahmed. I mean, regarding the first question, I mean, your question a bit too long a little bit. The first part of the question, remind me with it, please.
It's about the pre-existing immunity.
Yeah, pre-existing immunity is not my word. It's actually Zinkernagel, which is actually pointed to that the people, sometimes they do have this pre-existing immunity before actually anything happened. And people encoded this type of antibodies in their germline genome before actually any mutations happen. So they didn't see any viruses, but they do have a much better immunity because of this pre-existing antibodies. And I wasn't sure about that until the very strong evidences have been coming out, especially with COVID-19. And this may explain a little bit, or actually evident now, because before 3 weeks ago, nobody had been hearing about it. But I'm telling you what's up to date, that some people are having these antibodies, which make them actually more immune against the virus. So when they get the virus, they may not notice it at all, and eliminate it in the first 3 days before any symptoms.
So it's inherited, not because of course.
No, it is inherited. It's in their genome, and this is why we wanted to do the human genetics one day, to look for something like that. So we have this study alongside. Okay. About the study of the French about the hydroxychloroquine and working with the lysosomes, it's not confirmed yet. It's not confirmed yet. But I would say the most of the studies didn't show actually a much better impact on the virus infection using hydroxychloroquine.
No, it's not starting from drug. It's a chloropromazine, which is antipsychotic.
You mean the chloropromazine for these antipsychotic drugs?
Yes, but
yeah, I mean, I mean, at the moment, there is no evidence that any of these drugs are showing an impact of the. In fact, actually, a lot of these studies have been showing that hospitalized people for the mental health, they usually actually infected more than that. So there's nothing on the basis of epidemiology which say that the chloropromazine has the advantage.
Yeah, we have a few questions. And Professor Hassan, you said you have some teaching duties. So I have a list of questions.
Dr. Walid,
very interesting.
I mean, who's having a teaching duty can go. I think the teaching
Dr.
duty
Walid,
cannot be happening.
Dr. Yasser, I have a question for you, Dr. Yasser, which is, can anybody have two type of vaccines, two different type of vaccines? I think this is the common question between some of them.
Thank you very much.
Professor Hassan, would you be able to help me promising all people that who have raised their hands and having questions that will answer their questions? So we'll stay till answering all the questions, Professor Yasser?
I promise I will stay here until answering all of the questions. I tried to be fast on my presentation. I just wanted to focus on the vaccination, but I wanted to match the teaching.
Right. I think it depends
Dr.
on
Hassan.
Dr. Walid here, right? So
Walid Khatib.
So let's Dr.
Thank you, Dr. Yasser, for your interesting.
Thank you very much.
Thank you, Dr. Yasser, for your interesting presentation. Actually, I'm curious to know, would the current vaccines be effective against the newly mutated B117 strain or not? Is there any studies regarding this? Also, I have another question. What's the relation between melanin and immunity against the SARS-CoV-2? Thank you so much.
Thank you very much, Dr. Walid. Very important questions, I have to say. I will start with the second part. With the melatonin, it's evident by other publications on other viruses, but not in COVID-19, that the melatonin is protecting against the viruses, in particular in children. And the link for that with the bats, that they have very high levels of melatonin, is actually giving another confirmation from another species. So how and why and mechanism, don't ask me, and I don't know yet. I know the scale on the top.
Because actually melatonin is one of the antioxidant, and this is one of the most famous antioxidant from the pharmaceutical point of view that can enter the cell. Most of the antioxidant like vitamin E, C, E wouldn't be easily enter the somatic cell, but exceptionally melatonin can do this task easily. So I'm curious. I think we have to make some studies regarding melatonin and its association with SARS-CoV-2.
Yeah, this is an interesting one. However, the antioxidants is not confirmed to be actually a good fight or a good weapon against viruses, to be honest, because you can give a lot of antioxidants and it will not improve. The most important for treatment against the viruses is to give a vaccine which gives you a neutralizing antibody. And this is go back actually to your first part, which you said to me is B117 strain, which spread now like fire everywhere. Is it actually can be stopped by vaccine? We believe yes. And we believe that we should actually have a good faith in our vaccines, because until now, we believe that we have a very long spike protein actually encoded into AstraZeneca, for example, or actually in the messenger RNA of, so probably it will form a lot of antibodies about which can neutralize this new strain, because the new strain has the capacity to bind to the cells better, but it doesn't mean that the antibodies which formed from the vaccine cannot eliminate it. Okay? So this is the factor which make it spread very fast. Okay?
Okay, thank you so much.
You're welcome.
The last question is the difference between the beneficial antibodies and neutralizing antibodies and the unbeneficial or harmful antibodies that help the virus to enter the cell through Fc receptor on the cell. So what is the main criteria that can differentiate between both antibodies regarding beneficial and harmful antibodies?
It's obvious. This is neutralizing antibody. This is not neutralizing antibody. And you can go and look for any basic immunology book about what's the difference between neutralizing and non-neutralizing. But what I'm saying in Arabic words, الضربات التي لا تقسم ظهرك تقويك. If you are not in neutralize the virus, means that you are stopping it from infecting the cells and easy to be eliminated by the phagocytes or by any other immune cells. The antibody actually enhance hooking it into another cell and allowing to go into the cell, because it's not stopping it, it's actually taking it inside. While the neutralizing antibody is stopping a function of the virus itself. Thank you.
I mean, both of them combined. I know very well. I am actually professor of microbiology and immunology.
I know that.
How the neutralizing antibody work, but I mean, both of them combine the virus. And the antibody, the FC receptor combines the FC part of the antibody combines the FC receptor. So how would the virus escape the Fab and multiply inside the cell after engulfment into the dendritic cell or phagocytic cell? This is
a very specific point. I can sit down with you on a previous on another Zoom and talk about that.
Okay, that would be great.
I can provide you actually with a lot of recent publication about that.
Thank you. This is something I would be happy to arrange a special seminar or webinar between Dr. Yasser
we'll make a debate.
And Dr. Walid, Dr. Walid is the Vice Dean of Faculty of Pharmacy at
MashaAllah, MashaAllah. Yeah.
Thank you so
Dr. Walid for maybe 25 years, Dr. Walid. I haven't seen you for about 25 years, maybe like that.
Thank you so much.
Okay, we have...
Can I ask a question?
We have questions here waiting. Mervat Khalil first. I have listed all those who are asking questions. Mervat Khalil first, please.
Good morning for all of you. Thank you very much, Dr. Yasser, for inviting me. Okay. Thank you, Dr. Yasser, for inviting me. Thank you, Dr. Amara, for hosting this lovely presentation. Well, my question is very simple, but it's being asked quite a lot from the public. Would the vaccination be safe for people with autoimmune diseases or autoimmune disorders such as lupus or rheumatoid, or just till the end of the list?
Yes, it's a very important question. Thank you, Mervat. Actually, very nice question, because I'm specialized in autoimmunity. I receive that by emails every day. It depends on the condition. If the autoimmune disease can stop the immune suppressant for 3 weeks without any flare, you can actually take the virus, the vaccine for the virus. Which vaccine that you recommend, if it is your choice, take the messenger RNA vaccine.
Oh, right.
It is better, because actually the autoimmunity, in particular lupus, is activated by the viruses in particularly, and the messenger RNA is maybe flaring them. There is no point of taking the vaccine if you are on immunosuppressant drugs. So steroids or Motifil or anything of these drugs will be immune suppressants. You shouldn't actually take any vaccine while you are taking these drugs. So you have to have weaning from then take the vaccine, and you can actually wait for 3 weeks for the immunity to build up, then fading out. And I can forward to you in particularly what our French friends actually talk about it in this context.
All right, thank you.
Okay, so just to highlight again before going to Mohammed Razzaw for his question, that this is live now on Facebook and will be recorded, and I'll send it to you, Professor Hassan, to upload it on Galala website after download it. Mohammed Razzaw, please.
I think there is a question from Professor Samia Lazab.
Thank you very much for this.
I'm the Dean of Applied Health Science Faculty at
really?
Thank you for this valuable lecture. And I wanted to ask a question about a drug called Ivermectin, which is antifungal drug. Dr. Yusri Aql said that it can be give prophylaxis effect if we take 4 tablets one time, and after 8 days take another 4 tablets, and after that every month we can take 2 tablets. Is it true?
Well, I don't like to argue about any drugs which at the moment, believe me, Dr. Tamir, if there is anything which can protect against COVID-19, it will be sold for free here in the UK. I mean, it would be given for free in the UK. Everseen has the same effect like hydroxychloroquine. It's something which interferes the immune response at the beginning. It's all coming out to the first 5 or 6 days where we have innate immunity. And everybody was thinking at the beginning that we have this cytokine storm because we have unlimited effect from interferon. And it is confirmed in the last 3 or 4 weeks that the interferon are the most important cytokines doing that. So we try actually to not interfere with the immune system in the first 4 or 5 days. If that passes, that's fine. If there is a cytokine storm, we will not use Everseen for protection. We will use actually cortisol or decadron to suppress this bubbly effect which happen. So I'm not objecting about using Everseen. I'm just saying that we have to understand what's going on, and it is different from one patient to another, so we cannot generalize the things.
It is as a prophylaxis, not treatment.
I know.
Yes.
It's exactly the same concept which hydroxychloroquine used for the blocking of TLR9 and TLR7, which is the receptors for the viruses. It's not the treatment is not to blind the immune system from the virus. The treatment actually, remdesivir, is much better than that. But you cannot give a drug with 4,000 pounds a packet for treatment as a prophylaxis. And I don't prefer to blind my immune system from seeing the virus to protect myself, because I may actually develop a new strain or a new variant, or actually maybe have a worse disease later.
Thank
Professor
you.
Ashraf is asking, is raising his hand. Professor Ashraf.
Professor Ashraf.
I again thank you everybody for this very fruitful webinar. And I have a question here regarding the different immune responses and between different people and between different strains of the virus. Does this have any relation with the possibility of having vaccination of 2 different vaccines? Because we heard some of the professors from the UK actually saying, answering one question related to if it's possible to have 2 different vaccines. Does this give you extra immunity, or it looks strange for me at that time, but actually this question was propagated, and with a different type of strains that is getting in the market or in this epidemic. I would like to ask this question: does having vaccination from 2 different vaccines adds any value or adds any risk? I don't know.
Thank you very much, Dr. Ashraf. It is spot on also a question. It was me who said that, I have to say, in the media. It was asked actually in the media by a certain presenter in the media, and they asked me about if we can take 2 vaccines at the same time to enhance each other. Can I share my screen again, please?
Just a second. Okay. Yes, you can do it now. Yes, go on.
I wanted to drag attention on a certain part, just to answer this question particularly, because I actually I was overwhelmed with the time at that time. Sorry, guys. In our vaccines, we have 10 types of them. Usually, if I take that in 5 minutes, I would say that, but I want just to cover this point. Most of the vaccines are very similar to each other. So if you have inactivated vaccine like Sinopharm, Sinovac, Valneva, which is actually in the UK, very similar to each other. And there are other forms which are using the same on each category. Believe it or not, most of the vaccines against coronavirus are focusing on this spike protein. Either they make the spike protein, or you're giving the spike protein in the form of proteins, or you're giving the spike protein in the form of particles on the top of nanoparticles. You are working on it. So there is nothing new you can add by adding another virus of the same category. In the messenger RNA, you are also making a spike protein by the messenger RNA that you're encoding in the cells. The same thing happened with the DNA, because the spike protein is the most specific part of the virus, Dr. Ashraf, and that's why giving two types of vaccine at the same times may not actually solve the problem or give you two enhancements. In fact, if you are giving, for example, AstraZeneca, Oxford against Sputnik, they are having two types of non-replicating virus doing the same thing, which is giving a spike protein infection to the cells to produce this gene. I have to drag attention to that some of the people think that maybe some of them, they're better than the other because they produce the double immunity that we've been talking about for T cells and antibodies. And another one gives actually antibodies more than T cells, but you are using the same stimulant, the same spike protein. So there is no, in fact, a difference in the vaccination process. It is only the method of delivery of this spike protein inside the cells, or the inside the immune system, or to the immune system. So, however, I have to say that for the honesty of the science, there is a lot of studies happened before on another viruses called the heterologous prime support, and the heterologous science support suggests one dose of certain vaccine, another dose of another type of vaccine, which happened about 3 or 4 weeks after, which give you the immunity in by another way. However, they found that it is not the best method, because you are not sure if the best vaccination happened from the first dose or the second dose, or if there is a failure, is it happened due to the first one or the second one? So in my suggestion is to stick with one type of vaccination. And the two that Egypt have been providing by Wizard al-Sahha al-Sukkan are the best, in my view, in the world, which is the Sinopharm inactivated, well-known, very safe. Yeah, it doesn't give you a T-cell response that much, but it gives you the most safe one. And the AstraZeneca one, which is the most efficient one, and you can leave it in the fridge for a long time. And as I say, the advantage and disadvantage that I mentioned here, but I stepped it very fast due to the time, that AstraZeneca will give actually the T-cell immunity as well as the neutralizing antibody that we are looking for. So I felt relieved yesterday when I've heard that Sisi and the team of the responsible about this have been deciding that they have to go ahead with these two vaccines away from the other types. So I didn't like to focus on the other types because this is what should concern you. But don't take two vaccines, stick with one, will do the job.
Thank you very much.
Dr. Yasser, Dr. Walid, I would like to thank you very much. It's a very interesting, and it's a pleasure to have you, Dr. Yasser, on this webinar. And I would like, in the near future, to have you on campus for probably for another topic, not COVID. We would like to get rid of COVID as soon as we can. Thank you very much.
Too many things, don't worry.
And thank you very much, Dr. Ashraf, for joining us. And thanks very much for Dr. Ali Sabur also joining us. And thank you very much for Professor Shenawi joining us on this webinar. And thank you for everybody joining this one. I know it's a difficult situation now. Everybody try to join from home or from office or from road or from car as we're doing now. So I would like to thank you all very, very much and stay safe.
Thank you so much to Professor Hassan, and looking forward for having Professor Yasser very soon, inshallah, in Galala University. And looking forward for more cooperation. And we are open for all types of cooperation, especially that we have great minds now in Galala, and really looking forward for future cooperation and having and welcoming you in Galala University.
Thank you very much, Dr. Shenawi. Thank you, Hassan. I'm honored to be with you today, and I hope that I was helping everybody understanding a little bit about this.
And just
thank you for the fruitful discussion and questions.
Dr. Yasser, I just want to, Dr. Thank you very much, Dr. Yasser, for this very successful webinar. And thank you, Dr. Hassan, for having this done and arranged. And of course, all the thanks to Dr. Mohammed Al-Shenawi, who's doing a great effort in the internationalization component. And of course, Dr. Yasser, you are welcome at Galala University. And we are looking forward to have a short visit probably after having this corona virus endemic done and out and finished. We hope to have occurring in the coming summer. Yeah, hope so. Yeah, vaccination will be effective. We hope so. So you're welcome anytime, of course. And of course, if you know that we have been told, I'd like to have this exposure also to the students in topics related to the technology and your experience in this. I think that's a very important issue to be having exposure to the students. So please, Dr. Hassan, arrange for the different groups of students. And again, another webinar. Of course, we're just going to open it, and the staff members of the School of Science, both or three fields and programs that we have, will be very interesting to have you with our students. Thank you very much indeed.
Thank you very much, Professor Ashraf. And I would like to actually give a special thanks to the man behind the screen, Dr. Walid Amara, is actually helping us on this Zoom webinar. Walid is our colleague in UK, and we're expecting more, inshallah, very soon from the UK academic
together
toward our countries. Yeah.
Thank you very much. Thank you. Thank you very much. Thank you all.
Thank you very much. Have a good day. Thank you.
Have a good day. See ya.
Bye.
Bye bye. Salam alaikum. Salam alaikum.
Bye bye.